I'm
Bring
just
it
not.
on.
Huh?
Bring it on.
Bring it on. Okay, do you see it?
Yeah.
All right, guys.
We're in the lung this time.
We're in the lung. Here's the background lung.
It's normal besides some smoking in the background, and then. And this is a mass they're going after.
That's correct. Yep.
And it's a middle-aged older person.
Yeah, that's fair. Older person. And the only what they gave is a right-sided lesion. That's very helpful. Lesion is the most helpful history I've ever heard.
Any imaging findings?
Imaging, I think, was just, I don't know for sure, Raghav. I think it was just mass.
Okay.
Lung mass or lung nodule, something.
Yeah, yeah.
But actually, going by this, it probably was some sort of cystic, with a cystic component. But I'm not sure.
It almost looks necrotic.
Yeah, correct. Correct. That's exactly right, Matt. All right, so let me see how high I can go on this. I think this is my highest mag.
Does the patient have any malignancy?
Yes.
Good question. Good question. Good question.
It's a
good question, Irene.
It's a woman?
Yes.
I guess you're not going to tell us what her previous
No, I can tell you if you want to know.
Well,
I
guess
no. Yeah, let's commit and then we can ask the previous malignancy. Let's commit to something.
Okay. Yeah. I mean, it's not fair. That's not what you would do at Frozen. Like you would look it up, right? You would say, or you would like. In fact, Matt looks up his thing ahead of time, which is like extra conscientious. He looks up the OR scheduled cases beforehand, so he knows the clinical data bit. That's like really above and beyond amazing.
Yeah, that's amazing.
I would do that too. Like if I'm stuck on a case, I would ask my resident, hey, can you just see if there's a prior history? If we have a breast sentinel node, I often ask, was it lobular or ductal?
Yes,
Things like that.
Yes.
The other thing I find helpful is if things I know are going to probably be tricky, I usually pull the previous biopsies.
Yes.
And then it's actually really nice to have that as like your positive control of which, especially for margins and things.
I don't know how it was when you guys were there, Mayo, at Mayo, Matt and Raghav, but they used to have the fellow do that all of it before.
I did. Yeah. It's still there. Yeah, it's still there. We used to prepare the report the list. The list or the OR list, and it used to be like you have to go through so many cases listed in the OR, like 100, 200 something, and then you make a list of 30 or 40 and you present it in the morning before the starting of the sync day.
Yes.
And then again, sometimes you have to be long, give the previous history, sometimes you have to be short, but I've seen that because there were so many cases, we never used to remember when the actual Frozen came.
Yes. So Irene, can I ask you, in your institution, like when you have a Frozen section, do you have your residents research the case before the Frozen starts?
I do. The surgeons call me before, and I check what's the issue, and if it's a difficult, if it has been something like this, I would have pulled the case.
The surgeons call you beforehand and they tell you?
Yes.
They do. Wow, that's great.
They text me and say
wow,
there is something. They don't write in the report, but they write me, so they are nice.
That's great.
We here also we generally have the list discussed in the morning without the attending. The PAs and the residents, they usually discuss the OR list. But what system I have is when they page me, they usually page the attending when they get the specimen. And then immediately I go and get the number, and then I look it up before actually the slides come up. So I am actually having some information beforehand, like previous slides, reports, or previous history of cancer, or imaging findings, those kind of stuff. I usually have it in hand unless I'm making a blunder.
Makes sense. All right, guys, you want to go ahead and make your guess?
I say malignant, sarcoma, metastatic, pulmonary myxoid sarcoma, because I was imagining a big old like airway dilated kind of thing.
Yeah.
So those are my thoughts.
Okay. And Matt has spindle cell neoplasm question metastatic.
Yes.
And Irene has
stroma sarcoma.
Yeah.
Metastasis.
What was that?
Stroma sarcoma. This GYN.
Endometrial
sarcoma metastasis.
To say one.
Yeah.
You guys are very, very close. Very close. The history is of synovial sarcoma.
Yeah.
Okay.
And actually the frozen was called focal residual lesion. So I think there might have been prior therapy, which is why this is so hemorrhagic and sort of necrotic looking.
Yeah.
So the question might have been, is there any residual sarcoma left in the lung? Maybe that was the I don't know the details, but maybe that was the question. But now you can see, right, why it looks like this blue kind of spindle cell thing. Yeah, so that's all. On frozen, all they said was residual lesion present, and they didn't commit anymore.
But that's probably all they needed, right?
Yes, correct. All right, guys, that's it from me. Yeah.
Well, it's
I have an interesting question. So the synovial sarcomas before, in the past, they used to diagnose on morphology. Sometimes they used to have just CD99, never used to do EWSR1, those kind of stuff.
Yeah.
And then later on, like if those cases recurred or came back, we don't know about the versional diagnosis because it was purely on morphology. And then later on, if they try to reclassify the case, do EWSR1 rearrangement, if that tends to be negative or absent, and then they're wondering about all different kinds of sync of different tumors. So do you guys experience those kind of history in this? What once thought as having sarcoma, but now turns out that it's something else to begin with?
Yeah, I'll let Matt or Irene go first, and then I'll tell you mine.
You mean that the things that were diagnosed as a synovial sarcoma now that don't have the translocation?
Yeah. Yes.
I experienced something coming as a synovial sarcoma to perform the FISH in my hospital, and it had not the FISH, and we looked it again, and it turned to be a myofibroblastic tumor.
Yeah.
Only because it expressed TL1 that in the beginning, as every stain seems to be so specific, but then you find out that it stains many things. So this was the soft tissue pathology was the one that said it has a lot of inflammatory infiltrate. Must be this thing, and it was.
Yeah. I guess this not uncommonly happens, especially with these fusion NGS panels, right? Where, once you throw it into this thing that tests everything, right, you find some novel fusion that actually classifies it as something else, right? And so I think this is not uncommon, and it would probably become more common as we start to throw more things into these very broad NGS panels.
Yeah. At mine, Raghav, I mean, I've seen it only rarely because honestly, I don't sign out any of the sarcoma things myself. It all goes to our sarcoma people. But anecdotally, yes, it does happen sometimes that first of all, I don't think we can blame somebody who was practicing in 1990 or that they diagnosed it by morphology. That's how it was in that time. There was no
correct
on that. But I think also even in the current age, the reverse also happens. Once you have a FISH confirmed something, right, like a FISH confirmed synovial sarcoma, do you have to keep repeating it every time it metastasizes? I don't think so. So you can just let it go if it's consistent morphologically. So the reverse is also an issue.
Yeah, you can just pull the slides and just compare them.
Compare them.
With NAT carcinoma, it's different, no? Because it's apparently a carcinoma, but now maybe it's a sarcoma and it has fusions, and you don't know what it is, and this NAT appears, and it's I don't know,
it changes to something else. Yeah, that's problem. SMARCA4 is similar, right? I mean, there's some terminology issues, and now this marker is available. So things that were formerly poorly differentiated carcinoma or poorly differentiated malignant neoplasm is now SMARCA4 deficient thoracic undifferentiated tumor.
Yeah, I think there's an important point about that is that you can also lose SMARC in carcinomas too. It's actually not that uncommon. So if you test a whole bunch of carcinomas for SMARC, there's actually loss, and that doesn't make it a undifferentiated thoracic tumor, right? It's just your carcinoma that has SMARCA4 loss that might portend a worse prognosis, but it doesn't turn it into these undifferentiated tumors, right? It's somewhere in the order of 5 to 10% you can see SMARCA4 loss.
Yeah.
And right, if you look in the large genomic databases.
Correct.
So it's I think there you can actually go too far with some of this genomic stuff, right? And that, it has this genomic, therefore it must be this, right? I think you have to look at it in the context of everything else.
Yeah. I don't know if we should be having these entities based in a molecular alteration. Yeah. I know, because what about ALK? ALK is something that was for lymphomas. Should we begin calling adenocarcinomas lymphomas because it had ALK? But this is happening. We are calling things a thing because have an alteration that we don't really know if many other things have.
Yes, yes.
It's very true.
No, great points.
Yeah. Interesting. Yeah, great points. Great discussion.
Awesome. Well, I think that's probably the time, so I don't want to take too much of everyone's day. So thank you everyone for joining. I think this was a lot of fun.
Yeah.
Maybe we'll have to do another one of these.